So next is appendicitis V4. A 23-year-old girl presents at 10 p.m. with a 2-day history of right iliac fossa pain, nausea, and low-grade pyrexia. How will you assess her? Take a history, including gastrointestinal genitourinary symptoms, last menstrual period, previous ovarian pathology, or pregnancy. Examine her right leg for the tenderness and peritonism. The classic signs of obturator signs are roving sign, pressing on the left, pain on the right, obturator sign, hip inflection, internal external rotation give pain, psoas sign, hip inflection, painful to extension. Appendicitis is primarily clinical diagnosis, but I would request bloods, white cell CRP, pregnancy test, urine dipsticks to exclude infection in the urine. Alvarado scoring system is in the literature as diagnostic, although its utility has been debated. If the patient is not septic and diagnosis is in question, I would keep her on free fluid and observe overnight. If she is not septic, I am certain about the diagnosis. I would start her on broad spectrum antibiotics and list her for tomorrow morning. If she is septic or peritonitic, I would start her on broad spectrum antibiotics and book her for theatre for that evening. So patient is not septic and diagnosis in questions, observation. Patient is not septic but certain about diagnosis, antibiotics, and list for tomorrow. And if he is septic and peritonitic, list now. What is the pathophysiology of acute appendicitis? Initially, obstruction of the appendiceal lumen due to ficolith, or worms or lymphoid aggregates or pathological lesions, then leads to the translocation into the appendix wall, triggers inflammation leading to vessel thrombosis, wall ischemia, gangrene, and perforation. Your patient has rebound dialysis tenderness. Her white cells are 14 and she is not pregnant. Clinically, you feel she has acute appendicitis. Would you perform an open or lap appendicectomy? So I would do laparoscopic appendicectomy. So, but in females, I will consent her for diagnostic laparoscopy plus minus appendicectomy plus minus proceed, because in female there is diagnostic error in more than twice than the male's patient because of the underlying gynecological conditions. Laparoscopy advantages: less pain, faster recovery, less wound infection, and ability to look for alternative pathology like ileum, lymph node, ovaries, and easier if I'm high BMI. Laparoscopy cons: long operating time, long learning curve, increased cost, physiological derangement of new peritoneum, damage to internal organs, and threefold increase in the abdominal abscess by laparoscopy. You do a laparoscopy and you find normal appendix and no other pathology. Would you remove the appendix? Yes, I will remove the appendix. The arguments are: there is evidence of appendicitis on macroscopic normal appendix for 25 to 30%. It prevents the development of diagnostic dilemma in future. It is to remove if less local pathology. Argument against: all operative interventions have risks. So if appendix is normal at laparoscopy, there is no need to remove it. A pragmatic approach would be to remove the appendix only if it looks inflamed at laparoscopy. The patient must be clearly told the diagnosis made at the laparoscopy and the procedure performed, and the longer term sequelae of removing a normal appendix at laparoscopy is we don't know. If one examination found a mass in the right fossa, how would this change your management? The differential diagnosis would be either it's appendicular abscess or the Crohn's disease in a young girl. So I would ask for a CT scan. If this showed an appendicular mass, I would treat her conservatively with the antibiotics and risk her profession has passed. I would not offer an interval appendectomy unless she is persistently symptomatic. If a patient is older, would you alter your management? Yes, I will treat initially with conservative management, but I will book a colonoscopy in all the patients more than 40, because sometimes sickle malignancy can present as appendicitis. A 12-year-old boy had an open appendicectomy 5 days ago. You were asked to see him in A&E with pyrexia, tachycardia, and a pelvic mass. What do? It sounds like he has a pelvic abscess, so I would sustain the child with IV fluids, oxygen, analgesia, take blood culture, commence broad spectrum antibiotics, and arrange an ultrasound scan. I would review operation note to see if the appendix was greenness, perforated, or ficolith was left. If ultrasound scan showed a large collection, I would discuss with the radiologist on call to drain the percutaneously. What is your antibiotic policy in the appendicitis? Once a diagnosis appendicitis is made, prescribe IV antibiotics. Patient should receive prophylactic antibiotic single dose 30 minutes before induction to surgery to protect against infection. When it was perforated, I would prescribe full antibiotics for 5 days and then convert to oral. What do you do if you find a segment of terminal ileum Crohn's disease during a laparoscopic operation? I would not remove the appendix as per ECCO guidelines due to the increased risk of intra-abdominal collection and fistulation. State clearly what you will do with the Crohn's segment. I will leave it as such. I will send for the medical management. You are asked to review a 32-week pregnant woman with right-sided abdominal pain and radiant markers. How will you assess her? So differential diagnosis: cholecystitis and appendicitis, urinary tract infection and pneumonia. The history of pain would give me some clues, and negative Murphy sign may exclude cholecystitis, but I would ask for an ultrasound to look for any inflamed gallbladder in the gallstones. I would also look for with the midwife to check the fetal heartbeat is normal. Ultrasound score was normal gallbladder. Would you ask for CT scan to look at the appendix? If available, I would request an MRI in the first instance, as this would give detailed imaging without any radiation. However, this option was not available. The local resource, a quick, accurate diagnosis should take procedure over concern regarding anal radiation. However, at the stage of pregnancy, I would be concerned that CT might increase the risk of childhood hemorrhagic pregnancy. With appendicitis, what operation would you perform? So again, both can be performed. I'm more comfortable in doing the open. I never done hit me in the gravid uterus. The advantages of the laparoscopy over the open surgery are decreased fetal respiratory depression due to diminished post-operative analgesia, diminished post-operative maternal hyperventilation, short hospital stay, decreased uterine irritability, less need for uterine manipulation as compared to the open surgery. Thank you.